So continuing, we started with diagnosis and then went on to the non-responsive, what to do for the BCG failures. Now, going one step ahead, what do you do for the high-grade T1 bladder cancers? Is bladder-preserving protocol trimodality therapy a viable option? I call upon Dr. Nikhil Kalyani to come and educate us on this.
Good morning, everyone. I will be presenting a paper, bladder-preserving trimodality treatment for high-grade T1 bladder cancer, results from a Phase II protocol NRG Oncology, RTOG 0926. This was published in JCO last year by Douglas et al. So, bladder cancer is relatively uncommon cancer. Trimodality treatment versus cystectomy is comparable for a muscle-invasive cancers. However, for a recurrent high-grade T1 cancers, the cystectomy is currently the standard of care, and role of trimodality treatment is currently undefined. So, this was a study as a concepts as a single-arm Phase II cooperative group trial. They included patients with a recurrent high-grade T1 bladder cancer who had failed a prior BCG therapy or they were ineligible for BCG therapy. All the patients were advised cystectomy and they were medically fit for undergoing cystectomy. The primary endpoint of the trial was 3-year freedom from cystectomy. There were multiple secondary endpoints like freedom from cystectomy at 5 years, distant metastatic rate, local recurrent rates, the deaths from the bladder cancer at 5 years, overall survival, and the treatment related adverse events. Coming to the treatment protocol, all the patients enrolled in the trial underwent a TURBT to confirm that it's a non-muscle invasive T1 cancer. Radiotherapy was delivered using a 3D CRT in a two-phased manner. The phase 1 included the primary tumor bladder plus the pelvic lymph nodes to a dose of 41.4 gray, and a boost to the primary was given of 19.8 gray in 11 fractions, so total dose of 61.4 gray. Concurrent chemotherapy, they had given two options, either a concurrent cisplatin at 50 mg per meter square 3 times per week for 3 weeks over a period of 5 weeks, and second was the mitomycin C and 5-FU, day 1 of mitomycin C and 5-FU at week 1 and week 4 for 5 days. So they enrolled a total of 37 patients from 2009 to 2017. Out of 37, 34 patients were included for analysis because 2 patients did not receive the per protocol treatment. All 34 patients had completed the protocol treatment. The majority of patients were between 60 to 80 years. 90% of them were male, and 32 patients had grade 3 tumor on TURBT. The commonest toxicities were the GI toxicities and the myelosuppressions. The median follow-up of the full group was 5.1 year, and the median follow-up for surviving patients was 6.9 years. Coming to the results, at 3 months post-treatment, complete response was seen in 30 patients. The primary endpoint of 3-year freedom from cystectomy was 88%. The 3-year overall survival was 69.5%. The 5-year overall survival was 56.4%. Total 18 patients had died at last follow-up, out of which 8 patients had died due to disease and remaining patients had died due to other causes. The distant metastasis rate at 3 years was 12% and at 5 years was 18%. The local recurrence was seen in 12 patients at 3 years and 5 years local control was 32.4%. So these are the Kaplan-Meier graphs for the overall survival, disease-free survival and the local recurrence rates. Coming to the limitation of the current study, it's a small study. The accrual period is around 8 years for 34 patients and it's a heterogeneous population. So to conclude, for the T1 high-grade recurrent bladder cancers, trimodality treatment is feasible. It offers an alternative to the radical cystectomy. However, local recurrence and distant metastasis are still a challenge, and role of other agents and the immunotherapy needs to be explored. Thank you.